Hello and welcome to ID Talk, Answers from an Infectious Disease Expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and chapter immunization representative at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of July 19th, and as I record this is July 20th, Tuesday. Globally, there are 191,223,620 cases, and the mortality from the start of the pandemic globally is 4.1 million people. In the United States, our total number of cases since the start of the pandemic, 34,154,557, with 609,000 deaths, unfortunately, so far. In kids, from the AAP report dated July 15th, we are still at just over 4 million cases. That's 4,087,716 total cases, which is 14.2% of the total cumulative cases in the United States. That comes out to a rate of 5,431 per 100,000 children. Arizona, using that same database from July 15th, 149,353 cases total, which is 16.5% of the total number of cases in Arizona. Our rate is 8,123 cases per 100,000 pediatric age range from 0 through 19. Our number of deaths due to COVID or associated with COVID in the pediatric population is up to 32 in Arizona. That is the second in the country, second only to Texas, that has 54 cases. So this week's questions, not surprisingly, have a lot to do with the potential return to school and also impact and utility of the antigen testing. Before I delve into those, I think it's important to note that the total number of cases or the current status of the pandemic in the United States after a plateau is now starting to rise again. For Arizona, this may be the start of the fifth surge. Elsewhere in the country, the start of the fourth surge. As I think we are all aware from looking at the media coverage, this is largely to do with impact of the Delta variant, the B.1.618.2, initially from India. And that is now the prevalent strain and the most common cause of new cases in the United States. Last reported record from the CDC was 58% of all cases were the Delta variant. That's not the important part, believe it or not. The important part is that a majority, the near absolute majority, 99.3% of new cases of COVID-19 in the United States of America are occurring in unvaccinated people. Big surprise there? No, not really. That is incredibly unfortunate, both because we have large populations in this country and large sections of the country that are or under vaccinated, but also because we care for a largely unvaccinated population, that being pediatric patients, in part due to not yet having an indication or safety data for the vaccines available in children under age 12, but also due to still a modest rollout or modest coverage of vaccine delivery to children ages 12 and up. So this is important as we contemplate the start of the coming school year and what that means in terms of prevention techniques, distancing, masking, etc., and so forth. So with that, the first question, school starts in a month. Yes, it's coming. And we are not expecting our children to be masked, largely due to the governor's current decree that masks are not legal, or mask requirements are not legal by school districts. That is being challenged by at least 2 schools or school systems in Arizona. Hopefully those legal challenges will hold. However, we are also seeing the usual pediatric illnesses return as we have all come out from behind the masks. And certainly my local experience in Tucson has been an increase in respiratory illnesses, gastrointestinal illnesses, hospitalizations for dehydration and for respiratory distress. So there's a bunch of virus out there, which means there's a bunch of viral symptomatology out there, which means a total possibility of children presenting to our practices and our emergency departments and our hospitals for evaluation for diseases which might include COVID-19. The question goes, when school is back in session and our viral circulation is increasing, Will screening in the first 5 days with a negative COVID antigen test be adequate to return to school? Versus sometimes we needed to confirm a antigen test with the PCR or have a longer length of stay if the length of home quarantine based on symptoms. But basically, if our community prevalence remains low and despite the impact of the Delta variant, will a single negative antigen screening test be adequate to return to school? In part, of course, that is going to be a school district and a health department decision. But at least from the science of it, yes is the answer. It should be adequate. The risk is still going to be low for children, both in terms of acquiring disease, but also in terms of being contagious with the disease. Hopefully, kids age 12 and older will be vaccinated, but that, of course, is going to be a slow rollout as well. So as of right now, given the current community numbers, and unless they increase horribly, I would feel that a negative single screening antigen test should be adequate to send the child back to school. It's also going to be helpful using, here's that concept, our clinical judgment. Maybe perhaps we're actually able to do that now. We know in general that kids with COVID-19 are asymptomatic or mildly symptomatic. And when they do have symptoms, it's more often related to dyspnea and perhaps shortness of breath, perhaps with the GI component, versus the overt rhinorrhea, cough, congestion, sneezing, cold-like symptoms that we're more familiar with rhinovirus, other respiratory coronaviruses, influenza, adenovirus, parainfluenza, etc. So, that was a long answer to an excellent question. As of right now, yes, a single negative antigen screening test should be adequate to return to school. We'll see how that goes going forward. Next question then. As the positive and negative predictive values of those antigen screening tests change with community prevalence, should all the positive tests be confirmed with the PCR? Versus, again, our confirmation of negative tests by PCR, thinking that perhaps we were missing a significant portion of positive patients. Yes, although the antigen tests have decent specificity, it's not awesome, but sensitivity has been a bit better. All that said, there is still the potential to have a false positive, and because the impact of a positive test on a child's schooling, in person, or home quarantine, all of these are going to be important to confirm then by PCR if the child is truly positive. Okay, boy, here's the next. This is a great one too. There have been some recommendations to consider a broader pattern of a screening for respiratory panels due to the presence of other circulating respiratory viruses. And knowing that those tests, which are PCR based, are quite expensive, anywhere from $800 to actually $1,200 is a reasonably accurate prediction of the cost of a typical respiratory panel, which has anywhere from 10 to 16 targets. So what should we be considering using these screening tests when we have patients coming to us with respiratory symptoms? And the specific question is it reasonable to use our clinical judgment if the rapid antigen test is negative for SARS coronavirus 2? Are we obligated to consider using a respiratory panel, a $1,200 expenditure, to confirm the other stuff? Or can we use our clinical judgment? Well, as suggested before, I think now is the time when clinical judgment can come back. So having a negative screening test for SARS coronavirus 2 is appropriate, and after that, we can presume, based on symptom complex and clinical judgment, that the patient's symptoms are due to an alternate respiratory virus. So yes. Do we anticipate that private offices will be able to perform the vaccination of 5 through 11-year-olds once the vaccine indication and emergency use authorization is approved for the vaccines? Will states or counties decide this due to the amount of vaccine that is available? Well, as of right now, it is possible to register with the Arizona Department of Health Services to be a vaccine delivery site for ages 12 and up. That will continue to be so, I predict, for ages 5 and up and even younger once the younger indication is approved. So, yes, absolutely. Now is the time, if you haven't already, to register with ADHS to be ready to give vaccines for the age groups as they come online. Also importantly, and this is being coordinated through the Arizona chapter of the AAP and ADHS, there is the potential to share doses. For example, if you have recently thawed a batch of vaccines and don't anticipate using the complete batch, to reach out to other practices that may be ready to vaccinate with more and are not yet ready to thaw their own batch. So again, I encourage you to go through the AzAAP's website to find the links to coordinate and to register for the sharing of thawed doses. And then, do I envision healthcare workers to be required to be vaccinated against COVID once the full approval from the FDA is given? And would that extend to others who are staff members and working in a medical office? Wow, do I anticipate? This is a challenging one, of course. I think we've all seen how the court case came out in Houston with the hospital there, where the courts defended the hospital's right to exclude personnel, staff, physicians from working at the hospital if they chose not to get vaccinated. And the argument was that a hospital, and as with many other clinical entities, are private enterprises and can make that decision. So those of us in private practice or in a group practice that is a private enterprise, not county-based, should be able to make that same determination. Is it worthwhile? This is the difficult thing, right? The snap judgment, of course, is yes. Every single healthcare provider who has exposure to kids and works with kids and has potential to infect kids, absolutely, personal opinion only, should be vaccinated against COVID-19. That's a no-brainer. However, understanding that there are reasonable sources of vaccine hesitancy that can be addressed with support and transparency and answering questions and encouragement, rather than perhaps encountering even worse resistance by mandating such a course, I would hope that we can deploy our communications ongoing and openly answer questions as far as we are able before we take the step of requiring it. However, I do feel that an unvaccinated healthcare worker does pose risk to the patient population and to especially immunocompromised children, cancer patients, etc., due to their choice. I think a personal choice will have to be made, but I don't know that there will be a state-based mandate for that at all. Certainly not given my interpretation of the governor's approach to this pandemic. So I would suggest that practices, and perhaps this would be a great opportunity for another webinar to discuss openly within the chapter's membership, could we support such a move. If mandates of direct healthcare providers go through for vaccine coverage, that also should extend to anybody working at the practice, because every single individual ultimately will have some patient-facing encounter, whether it's the person at the front desk or even individuals who are providing support services. There is going to be some patient exposure at some point. And then the final question, can I explain the reason for increased cases in children under the age of 18 years? Well, I think that there are multiple potential factors here that we need to consider. The first, of course, is that children increasingly, slowly, but increasingly, are becoming the larger unvaccinated population as more at-risk adults and middle-aged adults are becoming vaccinated. Not everyone, unfortunately, not by a long shot, but those numbers are slowly changing, and who are being left behind are the unvaccinatable or the unyet vaccinated kids. So it makes sense that as we now have, and this is reason two, the Delta variant, which is clearly shown to be more contagious than the current circulating variant, the Alpha variant, the B.1.1.7 from the United Kingdom, it makes sense that any virus will be targeting those who are unprotected. And so the numbers, the apparent numbers, are going to change, and certainly the apparent proportion of COVID-19 patients who are pediatric is going to increase. What remains to be understood, and this is, I guess, hypothesis and answer number 3, is whether the Delta variant indeed is more contagious for younger aged patients. That is the suggestion that has not yet been proven by evidence, even in parts of the world, i.e. India, the UK, parts of Asia, parts of Africa, where there are circulating variants of higher concern. yes, children are being infected. Yes, children are having higher rates of hospitalization, but it may be that that is just because the numbers overall are higher, not that the virus itself is any more virulent or infectious. But that has been the prediction. And certainly this has been tested extensively with the South African variant, B.1.351, which does have a suggestion of being more contagious for pediatric populations. So I would suggest that the apparent increase in pediatric range COVID-19 cases is a combination of all those factors, the unvaccinated, the unvaccinatable, and also potentially higher risk to pediatric patients by the new circulating variant, the Delta variant. If this is so, not only will that pediatric population become more and more infected, but they potentially will become more and more contagious for adult secondary contacts at home or at schools or at sports clubs, etc. And this gets us right back to the concern about the governor's anti-mask strategy in school districts, school systems, as we navigate and anticipate the start of the school year. I would suggest, as does the AAP, the national AAP, in a recently released statement last night and today, that masking for children older than age 2 up through age, we'll say 19, remains effective and is suggested in the school setting for those certainly who are unvaccinated and unvaccinatable, and definitely for the ages 2 through 11 who cannot even receive vaccine. So the CDC supports this, the AAP supports this. I imagine most other science-based federal or national organizations would support masking in school because we are either at a point or about to be at a point where COVID-19 will become more contagious from kids to other secondary contacts, as has been seen year after year after year with the influenza outbreak and with other viruses such as rhinovirus, adenovirus, parainfluenza. So there you go. I think we're in a very difficult labile time in which absolute predictions are difficult to make. But I think it is fair to say that we can anticipate the next month is going to be rocky in terms of human health, both in the States and globally. And that's only going to get worse after we start the school year if we're unable to bring back mask strategy and social distancing to be effective. So that is a whole bunch about current Delta status and rapid antigen tests and other related things. Thank you as always for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Service Block Grant fundings. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meanwhile, hang in there, keep the questions coming, and thank you for your support.